Hi, Courtney DiNardo here from MD Anderson in Houston, Texas, and I wanted to update you all on an abstract that I presented on behalf of my collaborators and friends on the impact of post-remission G-CSF use on the VLA A and VLA-C studies. So just a reminder, in the randomized phase 3 VLA-A and VLA-C trials, venetoclax-based therapy was identified to improve outcomes with either azacitidine or with low-dose cytarabine, and this led to the approval of venetoclax in these combinations for patients with AML, newly diagnosed and eligible for intensive chemotherapy. And in both of these studies, cytopenias, especially with the venetoclax-based therapy, was frequent and was managed as per protocol, and G-CSF use, whether it was PEG G-CSF or like Neupogen, Neulasta, any of the various different formulations of G-CSF, that usage was allowed as per institutional practice. And so what we did is we tried to go back and evaluate the data and the effectiveness and the implications of using G-CSF for cytopenia management on these patients within the VLA studies. This is one of the most frequent questions the various investigators and myself receive as people are trying to figure out, is this a safe thing to do? We've always been kind of taught that it's not a great idea to use G-CSF for patients with myeloid malignancies because we could be stimulating the leukemia blasts, although in patients in a remission who don't have myeloid blasts to be stimulated, in the setting of neutropenia, is this a safe thing to do? So we conducted this post-hoc analysis to evaluate outcomes by the use of post-remission G-CSF. And so again, we're only looking at patients who had received a CR or a CRI, the composite remission, and then went on to receive G-CSF. And this was about 50%, it was 49% of patients on the VLA-A study, and then 43% of patients on the VLA-C study with low-dose Ara-C received G-CSF. So really kind of an even split of who did and did not receive G-CSF on the arms that were randomized to venetoclax. On average, the median number of cycles where G-CSF was used in those patients who did receive G-CSF was 3.5 cycles in VLA-A and 2 cycles in VLA-C. With a median ANC at the start, less than 500, and a median ANC at the stop of using the first G-CSF use was over 1,000, was 1.4 in the VLA-A and again 1.4 in the VLA-C studies. So the first question, of course, is, was it effective? And yes, we did identify that the occurrence of neutropenia in subsequent cycles, as well as the duration of post-remission grade 3 or higher neutropenia and incidences of febrile neutropenia were shorter in patients who received G-CSF as compared to those patients who did not receive any G-CSF. And importantly, the next question is in patients who are in a remission where you're using G-CSF, is this in some way negatively impacting their overall survival? And we found that that was not the case, that post-remission G-CSF use was not associated with inferior duration of remission. And if anything, actually, especially on the VLA-A, AZA-ven treated patients, the 12-month, the 18-month, the 24-month duration of remission was actually improved in patients who had received G-CSF. And this is a retrospective analysis, of course, and it's prone to many biases, but it was at least reassuring that patients were doing well. And similarly, overall survival was not inferior among the ven-treated patients that received G-CSF post-remission. And so I think, this is a post-hoc analysis and it's retrospective and there's all sorts of biases, but I think the take-home point is that it is safe and appropriate to use G-CSF for cytopenia management in patients who are receiving ven-based therapies. This improves the duration of neutropenia, helps prevent neutropenic infections, as well as not impacting in any sort of negative way the duration of remission or overall survival. And so that was the take-home point. I hope you found this informative, and thank you so much for your attention.